Welcome and good evening. I'm so happy to see all of you tonight. I know that there's other important things going on, but we are happy to have you here tonight to join us for this web talk. The first thing I want to say is that this is the second of a 5 series about health inequities. And tonight's web talk will be exploring our patient's context, a history of anti-Black racism in Cincinnati. Just a few housekeeping things to introduce our speaker, just so that we can be able to run the WebEx smoothly. The mic and the mute button down at the left-hand corner, if you press on that and see that it's red, that means you are muted. The next one over is the start video option. And we are asking that you press both of those buttons to keep yourself muted and also to stop your video so your video is not showing up. And then later on in the evening, we'll take question and answer. And there is a small round bubble that looks like a chat. And you can be able to click on that button to be able to type your questions regarding the chat. As the moderator, I will ensure that I check that chat box to get your questions answered. For the introduction tonight, go back to the slide for that, sorry. Our speaker tonight is Dr. Anna Gornasi. She's the program director with Geriatric Medicine Fellowship Program at the Christ Hospital, assistant professor in family medicine, and myself, moderator Jamie Gibson, nurse practitioner with CareBridge Palliative Care, as well as a doctoral student at the University of Cincinnati. Just a little bit about Dr. Gornasi herself. Let's go into her bio. Dr. Gornasi graduated from Virginia Commonwealth University as a journalism major, then attended the VCU School of Medicine. She completed her training in family medicine at the Christ Hospital / University of Cincinnati Family Medicine Residency Program, followed by the Geriatric Fellowship at University of Cincinnati. She is now an assistant professor in the University of Cincinnati Department of Family and Community Medicine, and the program director of the Christ Hospital / University of Cincinnati Geriatric Medicine Fellowship. She is a current UC student in the Masters of Medical Education program. Dr. Gornasi was recently awarded her HRSA Geriatric Academic Career Award with a focus on expanding on existing home visit curriculum for interprofessional learners to address the social determinants of health, mental health, and racism in medicine. Dr. Gornasi's professional interests include patient and family-centered care, home-based primary care, community engagement, and increasing diversity and anti-racism efforts in medical education. And without further ado, Dr. Gornasi.
Thank you, Jamie. I want to check too, is the slide up, the full slide up, Jamie?
You need to go a slide up, you said?
No, it's the full slide up right now. Just want to check.
Yes, it is.
Okay, great. Well, thank you so much, Jamie. Thanks so much for that introduction. I'm so excited to be with you all tonight. As we said, there are certainly lots of other things going on right now. So I thank you all for taking this time and recognize the current context that we're providing this in as well. So I wanted to briefly share my story. I was part of a racial reconciliation program at my church when I first heard this history myself back in 2015. And as I listened, I just felt that this is something doctors in trainings should hear. Many people should hear, but especially our doctors in training. And as someone that moved to Cincinnati myself, it helped me to see the city in a richer way and to better understand what brought us to where we are today, and also to see what my patients have in their history as well. So since that time, we've incorporated this into our family medicine residency training since 2017 as part of a larger anti-racism curriculum. So I look forward to sharing this with you tonight. As I said, as a physician and educator, it's important to be grounded in the historical impacts of racism. More and more studies are pointing to chronic stress due to racism as a source of the persistence of health and life expectancy disparities after controlling for socioeconomic factors like poverty and education. I'll start by reminding us that race has no biologic basis. It is a social construct that has often been used as a tool of oppression. Yet, race has considerable impact on health, in large part due to racism. The Journal of the American Psychological Association recently featured a series of articles exploring the physiological and psychological impact of racism and discrimination as it is related to chronic stress. Pervasive exposure to racism and discrimination creates an additional daily stressor for many African Americans. And racism has led to even intergenerational trauma. A review article in World Psychiatry in 2018 showed that there's intergenerational transmission of trauma effects through our very genes, through epigenetics. As we walk through the history of race in Cincinnati, I want you to listen for this thread of how racism and discrimination could impact health. This is the history my patients carry with them every day, carry with them into our exam rooms and our hospital beds. As I start, one note, I'll use African American and Black interchangeably throughout this time. And I also want to acknowledge the obvious. I'm a doctor that reads a lot and is committed to growth, but I am not a historian. I want to thank Dr. Tori Jackson, who is a historian, for providing much of the content of these slides and allowing me to use his basis and jump off from there. I also want to thank Jamie Gibson in advance for sharing her perspectives and experiences as we move through this history. Feel free, as we said, to contribute as well through the chat. Jamie will be monitoring this also. We'll move through this content in about 40 minutes, so it will also clearly not be an inclusive history, but a starting point. Finally, this is hard work and it's hard learning. I ask, you may feel offended at times or hurt, or this might trigger some stress for you. And I acknowledge that many of us are a bit more stressed right now than usual in a lot of different ways. So I ask you to dig in for this, knowing that you're doing the hard work to better care for our communities, our students, our colleagues from all the different backgrounds that are present here today. I would encourage you to recognize the emotions as they come and be willing to ask what those mean. This will be recorded, so if you need to take a break, do so, whatever you need to do. If you need to take a break to process and pause and come back or join at a later time, you can do that. So I encourage you to have some paper to write down any questions or thoughts along the way, and we'll have time for questions and discussion at the end, as we said. So let's get started. There are many Cincinnati stories. We're a city of immigrants, German Catholic and Jewish, that at times has been defined by racial division. We're focusing on race specifically today, and specifically the African American experience, because most health inequities in our city ultimately break down by the race line. I hope to draw a line from the Civil War through Reconstruction and the Civil Rights era to Cincinnati today to show that the racial inequities that we see affecting our patients and communities actually have deep roots in our history. We start with this. Many of you may have been here, but when you enter the National Underground Railroad Freedom Center, you can enter this slave pen that came from Kentucky. Slavery of Blacks existed for several decades in and around Cincinnati. Human beings were bought and sold, exploited, and assaulted. Legalized slavery ended in this nation 150 years ago, but the legacy and consequences of this live on. So we'll start our journey at the Ohio River. For a Southern slave, Ohio was a promise of freedom. Ohio was a free state from the beginning, with slavery outlawed in 1802. But the land of freedom proved elusive. Escaped slaves had to stay underground to avoid slave catchers as part of the series of safe homes in the Underground Railroad, which went through Cincinnati and Ripley, Ohio, near us. Many people try to get all the way to Canada for safety and freedom. And free also doesn't mean integrated. Racism quickly developed in a city of many immigrants of European descent. riots and unrest in the early 1800s. In 1829, the African American population in Cincinnati had doubled in the preceding years. And people were concerned, as poor white people were afraid of losing jobs and resources to this new population. There's a little known law that was part of Ohio's Constitution. It said if you were Black in Ohio, you needed two things to prove that you could be here legally. You had to have papers that proved that you were free, and you also had to pay a $500 bond in 1829, $500, to the state to prove that you were upright and productive. $500 just to be in the state if you were Black. Now, this was never enforced until 1829, as these growing numbers of African Americans in the city were seen. When the Black community appealed for a delay in enforcement, a mob of white people roamed through the Black neighborhoods, burning shacks and beating inhabitants, and ultimately about half of the city's 2,200 African Americans left, most to Canada. An unrest broke out again in 1841 after a long summer drought that led to large-scale unemployment. According to an account penned in 1841, what happened next was, quote, a most shameful outrage upon the colored inhabitants of that city, as white people threw stones against the dwellings of colored people, who returned it with a discharge of musketry. At one point, mobs even obtained a 6-pounder cannon and fired into a building where Blacks were hiding. Now, during the same time, Cincinnati also became an important community for the emerging abolitionist movement. Lane Theological Seminary, whose grounds are on Gilbert Avenue and Walnut Hills near us, was started by one of the most famous preachers in America at the time, Lyman Beecher. Beecher believed that the church could be a positive force in addressing slavery and had begun preaching forcibly against slavery as early as 1820. A few years after its founding, in 1834, Lane Seminary hosted important debates on slavery that began to turn the tide for the growing abolitionist movement. One of the younger people who heard the slavery debates was Harriet Beecher Stowe. Few books shaped American view of slavery more than Uncle Tom's Cabin. The book wasn't written in Cincinnati, but many of the themes and even characters in the book are based on relationships and experiences that Stowe had in this border city. And her home, as many of you know, is still available to visit in Walnut Hills. Cincinnati was also very much a part of the Civil War as a border city. Here's where it gets interesting. So Kentucky was neutral in the Civil War. Given that, when Abraham Lincoln issued the Emancipation Proclamation, it did not include Kentucky. It only applied to states that had rebelled and joined the Confederacy. And since Kentucky remained neutral and loyal to the Union, slavery was legal there through the entirety of the Civil War. It was only after the Civil War that slavery was undone just on the other side of the river. The Great Migration began in earnest after the Civil War, and particularly after the period of Reconstruction. Cincinnati, as you can see here, was a destination city and a pass-through during this period when millions of Black families left the South for opportunities in the North and to escape violent and repressive conditions of Jim Crow, lynching, and segregation. Yet, jobs were not as plentiful as hoped, and certainly the neighborhoods where they could live were limited. Resentment again built among poor white people who had been taught that Blacks were inferior and dangerous even. And as Black families settled in the city, many of the boundaries that still exist today began to develop. Carl Westmoreland, one of the senior historians at the Freedom Center, said about this time, again, quote, "We were damned, if you will, right off the boat. Cincinnati was born with a rigid pattern of class and race, which was only reinforced by later migration. A few days after the Civil War, the Cincinnati Enquirer predicted that Cincinnati would be inundated by a great Black flood, and people began to hunker down. And it's continued to this day." Next, I wanted to briefly touch on a challenging topic about lynching in America. Segregation was not the only hardship Black families faced during this period. Much of the Great Migration was fueled by families fleeing as refugees from racial terror. Racial terror, such as the KKK and public lynchings, were used to enforce racial hierarchies, disenfranchisement, and oppression against Blacks in response to emancipation. Local governments and police rarely stepped in, and sometimes, and often even, facilitated the terror. The threat of lynching led millions of Black people to flee the South to settle in the urban North and West. Over 4,000 racial terror lynchings have been documented from 1877 to 1950, and some would argue we need to change that 1950 to 2020. But millions more were terrorized by the threat of lynching. And lynching was a public spectacle with advertisements in the newspaper and crowds of thousands descending on a small town. Men and women were beaten, burned, shot, tortured, and sometimes dismembered, even, all in front of the crowd. Postcards of the dead bodies were even sold as memorabilia. Led by lawyer Brian Stevenson, the Equal Justice Initiative is working to document and shed light on our dark history of racial violence. They're also working to understand and respond to the terror and trauma that sanctioned violence created in the Black community. Transgenerational trauma that still has impacts today. I got to visit EJI's Legacy Museum and the National Memorial for Peace and Justice in Montgomery, Alabama a few years back. And since then, as a geriatrician myself, I often wondered about how many of my patients in their 80s and 90s have been impacted by the trauma of racial terror lynchings. How many witnessed a lynching? Patients often mention to me they were originally from Mississippi or Alabama, and I don't always inquire to what brought their family here. But I've been thinking about that a lot more. And how many of my patients were the legacy of refugees from this period of terror? In one family story from the museum, the father was lynched and the family fled to St. Louis, but only to be met with race riots. Then when they moved further north, they were victims of the KKK. Other families only find out about the history of lynching decades later and are left to sort through the delayed trauma. In this picture, Jesse Washington is being lynched, and he was burned before a crowd of thousands in Waco, Texas in 1916. Yeah, Jamie.
And I just want to kind of touch on that a little bit. And, I know Common Day, a lot of people say, that was so long ago. And my great grandmother lived until she was 95. And she was from South Carolina. And my grandmother lived until she was in her 80s. And their business surrounding making sure that you took certain roads when you traveled back down south, and making sure that you did not encounter certain gas stations. That was real. And for me to be 37 and remember that from when I was a child, for people to kind of still muster up the fact that these things are not real, it's not happening, it's dead now, don't worry about it. It's really disheartening because the things that people actually have physically and emotionally seen, dealt with, carries through the generations like you're talking about. So,
Absolutely.
As being a healthcare provider, I keep that in mind as I see African American patients and, their sometimes disconnect with the healthcare system, which you'll talk about later.
Absolutely. Thanks for that, Jamie. And I'll share that I moved here from Richmond, Virginia. So it was interesting for me to hear a little bit about, as you said, I've heard these, we're past it, or it's not a problem anymore. One good thing about Richmond is that we couldn't really escape our history. It was everywhere around us, as many of you heard with the monuments, the battle that's still going on around Confederate monuments. But sometimes we think we're a northern city, so we're exempt from this. But lest we think that the terror reigned only in the South. In 2019, the Cincinnati Enquirer shared the story of Chris Corbin, who's pictured here, a woman who lives in Fort Wright. She participated in a community remembrance ceremony in Oxford, remembering her ancestor, Henry Corbin, who was hanged in the public square in Oxford in 1892 for the slight of speaking to a white woman. And as Jamie said, this tragedy has been a part of Miss Corbin's family story ever since then. We know that a total of 11 lynchings have been documented in Ohio, including our neighboring counties, Boone and Claremont, but likely there are many more that are just not documented. As Brian Stevenson said, our nation's history of racial injustice casts a shadow across the American landscape. This shadow cannot be lifted until we shine the light of truth on the destructive violence that shaped our nation, traumatized people of color, and compromised our commitment to the rule of law and equal justice. We all must engage this history more honestly, which is why I'm glad you're all here today. That's heavy. To encourage you to take a breath if you haven't been doing so. So we'll go back to in cities throughout the North, working class African American communities emerged as a result of the Great Migration. And due to housing segregation, these neighborhoods included Black owned businesses and church congregations. And in Cincinnati, the primary Black neighborhood was the West End. For context, you can see the Union Terminal in the upper left of this photo. It was a thriving community with businesses, arts and culture, mix of incomes and careers, but it shouldn't be over romanticized. Due to segregation, as you could probably see in this photo, is overpopulated. It was also right in the middle of the Mill Creek floodplain, which flooded regularly at that time. As the population continued to grow, there was more of a push for neighborhoods to open up. At the same time, not only in Cincinnati, the same thing happened in Richmond, as I alluded to, there was a decision to place interstate highways right through the heart of Black communities, just as it did in the West End, ripping the community and social fabric apart. With the overcrowding and poverty in the West End, more Black families moved into other communities. Now, block busting began in neighborhoods throughout the city. In this process, real estate agents would buy properties in all white neighborhoods at value or even above value for a white family, resell it to a Black family desperate to get out of their community, then go to every family on the block and warn them to sell before their property value plummets. They bought the properties cheap and then resold them to Black families at an increased rate to make a profit. And this was often done on contracts so that if you missed even one payment, they could take that back and the property went back to the real estate company. This happened in neighborhoods throughout the city. With this began a great extraction of wealth from whites who were fleeing to the suburbs and from African Americans who were looking to leave crowded communities. Moving forward, as the 1960s progressed, neighborhoods began to change. Traditional white working class or Jewish neighborhoods or German neighborhoods like Walnut Hills, Mount Auburn, Over the Rhine, and Avondale increasingly became Black neighborhoods. But businesses in these neighborhoods were rarely owned by people of color. Tensions grew in Cincinnati and around the nation over oppression and lack of opportunities. And in 1967, Avondale became the epicenter of major racial unrest in the city, and again in 1968 after MLK's assassination. And this unrest led to further white flight with a resulting decrease in the tax base. Less money for schools, less money for sanitation, road maintenance, less money for the entire system. And the infrastructure in urban America began to crumble. Disparities in wealth and power grew as African Americans had fewer opportunities for jobs and far fewer opportunities for ownership. And some of the racial inequities in wealth and infrastructure that we see today started with this eroding tax base of the 1960s. But we didn't see segregation just in housing and businesses, but in recreation as well. The popular Sunlight pool at Coney Island was for whites only until 1961, and was only integrated after 15 years of protests and even arrests. Marion Spencer, the great civil rights leader in our city and our fellow University of Cincinnati alumni, who passed away at 99 last year, was part of this fight to integrate. For perspective, thinking about 1961, this was 5 years after buses in Montgomery, Alabama were integrated. And integration, while hard and systematically fought, took a little over a year there in Alabama. So in Alabama in 1961, you could ride a bus with a white and a Black person sitting in the same bus seat, but African Americans could not swim or go to an amusement park in this northern city of Cincinnati. Jamie, I know you had a little to share about Marion Spencer as well.
Yeah, I'm part of a historically Black sorority, and she was as well, a different one, but all in common. We worked to gain, you know, to help the community, honestly. And I do remember a videotape of her, and she was interviewed on multiple occasions, but this particular interview, she was talking about Coney Island itself and how she looked at her sons and had said to herself, if I can work towards making sure that my children have an opportunity to go to an amusement park and enjoy themselves without being fearful or shunned, why shouldn't I? And that really launched her thought process into, among other things that she did, because she did tons of things in Cincinnati, launched her idea into making sure that Coney Island was open to, you know, all people. And I live in Claremont County, which is not highly populated with African Americans, and Coney Island is in Hamilton County, but still really close to where I'm at. Right. And me and my children have gone there, and I truly, honestly thank her and think about that when I go there. That not that long ago, me and my children wouldn't have been welcome here, and wouldn't have been able to allow admission to get into this, facility. And now they can go and enjoy it, and they don't even understand fully the impact and the things that people have done, unless we talk about it to get us where we are. So it's amazing, like we talked about before, how people say that these things are so long ago, and really in actuality, this happening was not that long ago at all.
Right, absolutely. So meanwhile, remnants of segregation continued as well. So this is a title transfer from 1978. It's difficult to read, but it includes the following phrase: the above property shall not be sold, leased, rented to, or occupied by persons not of the white or Caucasian race. And this was still in a title in 1978. Again, that is not long ago at all. When you have a racialized history like we do in Cincinnati and in the US, the remnants and the trauma don't go away because a few laws were passed in DC. The remnants of systemic racism have a way of seeping in. I'm sure many of you were here in 2001 when Cincinnati was undergoing major racial unrest after 15 African Americans had died at the hands of police within 5 years. The data suggests that some of these deaths were justified shootings, but others were far from it. One, Roger Owensby, was an unarmed man who was questioned outside of a convenience store. After being questioned for a while, he decided to leave. Something transpired in the course of events, and he was thrown to the ground, pummeled, and kicked to the point that he couldn't breathe. And while the police officers discussed what to do next, he was thrown in the back of a cop car with the heat up all the way. Roger Owensby was dying in a police car due to asphyxiation. A few months later, an unarmed Timothy Thomas was shot and killed, and over the Rhine, and civil unrest ensued, and our city was torn apart. Jamie, I believe you had some personal experiences with that as well.
I did. At the time, my now husband was my boyfriend, and he had come down to University of Cincinnati as a freshman in 2000. And he had gotten an internship at Fifth Third. And as these riots started to kind of come up as he was in that second year, 2001, at school, I remember him being nervous, and myself at the time being very nervous because there was curfews that were incited, and then people had to be in the home. But he at the time did not have transportation, so he was taking public transportation back and forth to work and to and back to school. So for him, if he got off work late and it was starting to get dark, what did he do? Would he be a victim of something that happened as well, and the nervousness and uneasiness that we had as this time was erupting in the city? So just another kind of point of things that have happened in the Cincinnati area, among other areas, but in the Cincinnati area that kind of hits home with me, and me checking in with him and him checking in with me just to make sure that he made it through the day.
Right. And just to think about, we're talking about different levels of stress, and like the stress that you're taking on and he was taking on in the midst of that. And I'm sure his family as well. So I think it just goes across lines.
Yep, exactly. I think the stress levels on top of being a student, on top of working, all of those things in combination, having to worry about your life being taken potentially, really just trying to study and be a student, is quite a high level of anxiety that you have to deal with from day to day.
Thank you. So out of that, a group that included the Black United Front, business and community leaders, and the FOP came together to forge a collaborative agreement that makes Cincinnati an example in the country for police community relations and community engagement with policing. It put us in a different situation than what we saw back in Baltimore ago because of sacrifices and commitments made 15 years ago. But we are not exempt. And I know this one's going to hit close to home for many of us as University of Cincinnati faculty and alumni. The summer of 2016 came on the heels of many years of difficult stories and videos capturing largely Black men dying at the hands of police. And our city ourselves faced a major tragedy when University of Cincinnati officer Ray Tenzing shot and killed unarmed Sam Dubose following a traffic stop for not having a front license plate, which now, as of July, is no longer even required in Ohio. Officer Tenzing was charged with murder, yet both trials ended in mistrials, devastating the Dubose family, many in the African American community, and those fighting for justice for Sam and his family. These were two pictures ran by much of the media, Tenzing in uniform, and a previous mugshot of Dubose compared to this. Unfortunately, Sam Dubose was not alone. Freddie Gray, Trayvon Martin, Sandra Bland, Tamir Rice, Michael Brown, Philando Castile, Alton Sterling. Stephon Clark was killed in his own backyard. Tanisha Anderson was a woman suffering from mental health issues who, instead of receiving support that her family was seeking, died at the hands of police. Just this year, I have to add George Floyd, Breonna Taylor, Rayshard Brooks. Last month alone, we could add Jonathan Price, Marcellus Stinnett, and Walter Wallace to the list. We have to face that police interactions with Black people disproportionately end in excessive force or death. The legacy of racial division and injustice, the daily tension between police and communities contribute to the chronic stress that we as healthcare professionals know plays a major role in our patients' lives and also undergirds many of the health inequities that we see in our city. We have to reckon with the truth that many of our friends, neighbors, and patients do not feel safe day to day in our city. And Jamie, I just wanted to ask you, is this something that comes up with your patients? You've seen patients in a lot of different settings, and how have you seen that come up?
In a lot of different ways. I think the non-trust of, maybe in the community can kind of resonate into healthcare as well, where lots of times I feel like African American patients or families do not want to open up about their overall situation, whether that's their home condition or their health, because they're fearful that they, number one, may not be treated the same as their counterparts. I've had patients that will pull me aside and say, well, you're African American, so I feel like I can be able to talk to you about this. And then we get the ball rolling about what the real problems are, or why things have been happening. Whereas there might not have been a connection with, their other providers. So I think that's one, major thing that I feel like I've seen, in the healthcare system.
Yeah. Thanks, Jamie.
Mm-hmm.
The large challenge facing our community is found in major racial inequities between Blacks and whites in health, income, life expectancy, and economic opportunities. And one that hits hard for me is childhood poverty. Many of you will remember this. The Urban League released a report in 2015 called The Two Cities that highlights that we are still a city of two cities, separate and unequal. Some of the data has changed since this time, and we are seeing improvements in many areas. But within the last 5 years, we've had the second highest childhood poverty rate in America. At times, 3 out of every 4 African American children in the city are living under the poverty line. And we know that children are only poor when their families are poor. There are families struggling to make ends meet that are disproportionately Black in Cincinnati. In recent history, we've been the 5th most segregated city in the nation. So the challenge is it's easy to not see this. In a matter of miles, there are neighborhoods where you're expected to live 20 years less than another. I live in East Walnut Hills, and after I just walked 2 blocks from my apartment to Walnut Hills, the average life expectancy drops from 77 to 69. If I drive up the hill through Eden Park to Mount Adams, you'll see a 17-year difference between Mount Adams and Walnut Hills. And furthermore, Black men citywide have life expectancies 10 years less than their white counterparts. There's no easy answer to why this exists. Disproportionate amounts of poverty, access to healthy lifestyle behaviors, and the differing tax base we mentioned previously, and health insurance certainly contribute. Yet, in multiple studies, the life expectancy inequity persists when these factors are taken into account, suggesting that racism itself and discrimination in care also contribute to these differences. So let's all take a deep breath. This is my last slide, and we're going to be moving towards discussion time. So this is heavy and it's hard to hear, but it's also our truth. So we need to sit and reflect on what we've heard. There's hope and there's action moving forward, but we also have to deal with the truth that we've heard. And we know that there's action happening by many people on this webinar even, and it's an encouraging group to be a part of. Just recently, Preschool Promise back in 2016 expanded access to high quality preschool for all 3 and 4-year-olds in the city. We've seen ballot initiatives recently to change nonviolent drug-related felonies to misdemeanors, which would be a game changer in terms of employment, community health, families belonging together, and housing access. It didn't pass, but we know it made some more encouraging steps in the legislative area as well. City Council recently eliminated cash bail for nonviolent charges in Cincinnati, and currently about 3 and 5 inmates at the Hamilton County Justice Center haven't been convicted and are just awaiting trial without the means to buy liberty. This will change that, save money for the city, and return people back to their communities. And we've seen with COVID just how important this is, as we've seen the massive impact of COVID on prisons and jails. We've seen consistent community-driven work by committed organizations like Cradle Cincinnati that have led to a sharp decrease in the Black infant mortality rate to the best rate of record for Hamilton County. And this was largely driven by a decrease in the preterm birth rates, which is huge. We've also seen community organizations, funders, and corporations work together in new ways to serve the community during COVID. And as we see this picture here, we have this beautiful mural now from amazing local artists, including numerous UC grads, so many that I tried to list them and I couldn't list them because there were just so many, and organized by another UC grad, Brandon Hawkins. So as we wrap up, just want you to think about, I know we have people from lots of different backgrounds, but what can we do in our workplaces? For the doctors on the call, what can we do in our clinics and hospitals, in our learning environments for the teachers, in our businesses? For me, I've been trying to talk with patients more about family history and daily experiences of race and racism. I'm also learning more about trauma-informed care to better care for my patients dealing with intergenerational and daily trauma of living with microaggressions, and not infrequently, especially lately, macroaggressions. I encourage you to block some time for reflection in the coming days and make a commitment to one small step to get started. I thank you so much for your time, and I look forward to the conversation from here.
Dr. Bernassi, as we open up for questions and for more dialogue, we want to thank you for your presentation. It was amazing. It even kind of started me thinking more about things that I can do, even though I'm an African American provider, nurse practitioner, how I can approach my patients that have these traumas or have dealt with things in their lives that prohibit them from getting from one spot to the other with their health. I think one thing that I also had read recently, and I don't have the article in front of me, but it was really honing in on pain-related issues with African Americans compared to white patients, and how lots of times African Americans are diagnosed with and undertreated with their pain because it's believed, it's assumed that we can tolerate pain at a higher rate, or that we're not, or that we're not really in pain it's a fabrication, you know, it's not, that's not what the pain level really is. So then we're underdosed. And then dealing with these things, and we know pain itself can even change a person's vital signs as physicians, providers, and that also changes the whole dynamic of a person's health if that's ongoing. So just another thing that I really feel like you know I want to concentrate on is making sure I continue to listen to those patients. And as the question and answer portion of our evening, if there are questions related to Dr. Ganassi's presentation, we ask you to put that in the chat box so that I can be able to read those off and we can answer those questions for you for the rest of the evening. And right now, I don't see any at the moment, but we're open at this very moment to be able to start taking questions. So.
And while we're waiting for some questions, Jamie, I'll follow up with that. What you mentioned, that is, we talk about racism in medicine and how these beliefs, false beliefs, have continued through time. And there was a study, I believe it was 2016, a study of medical students, and they looked at some false beliefs that have been common in medicine. And one was specifically, like you said, that Blacks have higher tolerance for pain. And that was 2016. So, these false beliefs have continued. And it would be one thing if that's a false belief, but as you said, that belief leads to actions ultimately. And it means that a lot of our African-American patients don't have quality pain management, as you discussed.
Yeah, and honestly, with me working in palliative care and doing symptom management, I have felt like some of the African-American patients that I've treated are a little bit underdosed when we're looking at a formula to be able to dose them for pain management. I still don't see any questions in the chat box. What I do want to say is that I know that these topics tonight were sensitive, and we don't want anyone to feel unsafe. This is a safe space. So if there's questions that you have, we're open to discussing those questions, because I believe the only way to get us to a new place with racism and health inequities or disparities is about talking about it, and then talking about it, and then putting a plan into place to try to incorporate these new things into your care for your patients. So we're happy to answer anything that we can for you tonight. We did get one response saying, excellent, great presentation. Thanks so much.
Thanks.
Charlie's asking, any suggestions on how to reach out to African-American patients? In what way, Charlie? In just through healthcare? Like, what's your background? He or she, I shouldn't assume Charlie's a man. I'm a pediatrician and have very few minority patients and employees. I think it's just probably access. I think some of it plays into maybe access and also insurance coverage. It probably just depends on where you're at. I feel like some of the patients that I know of, I'll put myself into this. I said, I live in Claremont County, and the population of African Americans in Claremont County is not very high. So my children's pediatrician is a white woman, and we've gone to her since we've moved over here about 5 years ago. But as I've gone in and out, because I've got four kids total, as we've gone in and out, I haven't seen a lot of other African American families either on the side of town where I live or in that office. So maybe it's population. If we go back to the slides about where African American families and people live in the city of Cincinnati, maybe it has to do with demographics and where you're at. Maybe.
Right. And I think too, Charlie, I appreciate you sharing in there. You said that you have few minority patients and employees. I think part of it is, could you be intentional about the employee piece? Like, if the next time that you're hiring, thinking about reaching out to more African Americans for the hiring process. Because a lot of times we do know that a lot of patients feel more comfortable with staff that looks like them, and especially doctors that look like them, and actually have better outcomes in some studies with having a race concordant doctor. So I think some of it's that. The other thing, though, is just thinking about reaching out to your community where you are and seeing if there's ways, if it's a health fair or just ways to be out in your community and getting to meet people. But I think it's awesome that you're asking that question and being intentional and thinking about that. And that's honestly the first step.
I think a good resource too is the Urban League.
Mm-hmm.
And if I can get your information after this, I'm a part of a Black Cincy MP network. And our plan was to work with a lot of the health fairs in the city. So there's some health fairs that are geared towards African American population in the city, and that might also be a way because there's different booths, there's different healthcare agencies, all sorts of resources there. So that might be another way that you can dig into introducing more African Americans or minorities into your employees. Another question here: how do you deal with issues of higher risk factors in different racial groups when those groups have no biologic basis when you see them in the office? And that's from Charles.
Yes. Yes, I know Chuck well. Thanks for that question, Chuck. Yeah, so it is, I get this a lot. So if there's no race or no biologic basis, why do we get different outcomes? And this goes down to structural racism. So we know that and also a newer term for me, but environmental racism. So we know, for instance, if you think about air quality, a lot of our parts of the city that have worse air quality are going to be predominantly African American communities. Because of a lot, again, thinking about highways or where power plants are, those kind of things, those decisions were intentional. It wasn't intentional by us, but it was intentional when those decisions were made. So we have to grapple with that of like, what are the structural racism aspects that underlie this? So you can still know that. So I think it's more looking at exposures opposed to race. So if you know your community is more exposed to whether it's pollution, whether food access is more of an issue, knowing aspects can help you deal with that. And then the other thing is, how do we look differently? I think so. One example that we talk a lot about is with kidney disease is GFR. For those of you that are not doctors, GFR is looking at how our kidneys function. And race, again, talking about racism in medicine, race is factored into that. But that is also a very historical background with no evidence behind it. And so we see different outcomes, for instance, in kidney transplantations, and thus more African Americans being on dialysis. So how do you look at those and change how you look at it? So I agree. I think this is coming up a lot with colon cancer now.
About say that too.
Yeah, and so how do we change? Do we screen people differently based on that? The other piece we know for this, again, we think is that racism itself is what causes a lot of these differences. So just being aware of it, I think, is probably one of the biggest ways to address that. Jamie, what do you have to add on that one?
I was just going to say, because I worked at the Barrett Center with colon cancer patients, well, GI patients, but a lot of colon cancer patients. And I felt like I had a lot of young African American men and women. I feel like a higher rate of men that had colon cancer, and when they got diagnosed, it was stage 4. And I never did any research behind it, but I felt like there was a connection with not being able to get access to the things that they needed, or access to good foods, food deserts, and also the connection of not getting access to good follow-up and having the primary care to then launch them to say, well, you're a certain age, you need to get this done and that done for screening purposes. And then, compared to, some of the other patients that I saw that weren't African American, I felt like some of those came in and their staging was a lot less, with higher chances of less mortality and dying of the disease process itself. So I feel like there's just so many different layers to that, but my example being me working with the cancer patients themselves. So
Mm-hmm. Absolutely.
We do have another question. Any advice on starting those hard conversations with patients about the stress they have related to racism they experience? I think that every African American person is different. I feel like honestly just being confident in saying, is there things that you've experienced that have hastened or stopped you from coming to me as a provider or coming to other providers? Is there things that we need to talk about so I can make sure I'm delivering the best care to you? I think that's just a blanket statement you can use to help start a conversation with somebody to help gain their trust.
Mm-hmm. Yeah, and Maddie, thanks for that question. That is actually something our fellowship is going to be looking at, our geriatric fellowship is going to be looking at this year. I think you get at the point that a lot of us as white providers feel uncomfortable starting those discussions. And we're going to be looking at, are there best practices of how to do that or how to train, just like we train in, how to deliver bad news, how do we talk about racism in the context of patient care? But I also think we overcomplicate things too. I was talking with a friend about this recently, and I think if we ask about stress a lot in general and just, bring up, are there any sources of stress right now, or have you been more stressed than usual? And we're kind of finding that most patients or most people in general are definitely experiencing stress right now. And I think if you just open that door, a lot of that aspect of race is going to come out on its own. I've been seeing that more and more. I think the other thing is just that having those, and this is tough, part of my job is as a hospitalist, so I don't have that relationship, but I think the patients that I have relationships with that know and trust me are going to be more open about talking about that. But as I know Maddie, so as a medical student and as a resident, I think it just takes that connection and going above and beyond with connecting with the patient to make sure they feel like it's a safe place.
I think that we're not getting necessarily any more questions, just more comments. Thanking you, Dr. Granassi, and myself for being on this discussion overall, and opening more people's eyes to things that have happened in the history of Cincinnati up until present day. I think there's one more. Sorry, let me see here. I think this will be the last question we'll be able to take because we're getting close to the 7 o'clock hour. And I actually was just thinking of this. It says time constraints built into the healthcare business model can cause bias associated with gender, ethnicity, and et cetera, drawing an immediate association with noncompliance and diminished desire for better health. The end result may not identify real obstacles to high level of compliance. So I think that was maybe more general of just a comment. And I was thinking of this too. I feel like sometimes when you have a 15-minute window, I thought about a lot of this when I'm when I worked at the Barrett Center. You've got a 30-minute window, and you don't have the time to sit and talk to a patient about their, you get their history, you do the things benchmark that you're supposed to do, and go down the checklist. But that extra piece of care, where you talk to the patient about what's been going on in their lives and what got them to this point, sometimes lacks, and it misses, and you miss things about their overall situation that can turn into bias or turn into undelivered care the way that you need it to be.
Right. And I'm so glad you brought that up. I really dislike the word noncompliance, but it is so built into our structure, to your point, and I think it's the easier way to say things. So just over the last few months, I've been more intentional about trying not to use it. And it takes a lot longer because now I say, has not been able to take medications as prescribed because they weren't able to pick them up from the pharmacy, or because we gave them a really complicated regimen that they can't follow through on. But that takes a lot more time than saying non-compliance. And it's literally built into like some of our codes too. So I thank you so much for bringing that up. And I agree that we need to do more work on identifying the real obstacles, and that's on the system level too. I think it's one of the challenges we all are dealing with is that you as the individual doctor or as the provider have all of these different constraints on you when really we need to change the system. And I know many people are working on that as well, but it can't just always be that one-on-one relationship. We've really got to change the system of how do we better identify these obstacles and work as health systems to change them too. Just because we identify food insecurity, if we don't have a way to change that, what do we do next?
Right. I think I gave this example even on the last presentation about how I had a patient that we just could not figure out. We kept saying non-compliant. We could not figure out why she wasn't taking her medicines. And when we finally, and I sat down and had a conversation with her and just really said, I'm not understanding, why aren't you taking these medicines? You need them to be able to continue on with your health and stay healthy, with all your other medical problems. She admitted that she couldn't read. Because she couldn't read and there was a literacy problem, that was the reason why she wasn't getting the refills. And she was completing a bottle but not picking the next bottle up, not following the medications and so on. So, I think we are at the end of our time here. I think this was a great program tonight. I know that there were, like we said, there was lots of other things that people could be focused on tonight with the presidential race. But we thank everybody for coming on this evening and joining in on the conversation. And we look forward to the next part of the series, number 3. So thank you again.
Thanks, Jamie. Thanks, everybody.